dialing code, a resource for 24/7 phone line. Of course, 211s are available across the nation. Sometimes they're their own nonprofit organizations or they're part of United Ways. In our case, we are our own nonprofit organization and provide that service to the community, as well as a resource directory of services that are publicly available to people to be able to navigate the health, community, and social service resources available. We steward the Community Information Exchange. We believe it's a shared governance infrastructure that is really owned by the community that we're serving. And it's really around this kind of concept around an ecosystem of multidisciplinary organizations that's connecting through a shared information, technical infrastructure, and a governance infrastructure. So if you go to this, you just want to make sure that that's clear. So we have 2-in-1 operations almost, and then we have CIE operations that look very, very different. And so that's really the delineation. Across the nation, we're seeing United Ways are taking over kind of the backbone organization role or the stewardship role of a community information exchange, but also like here we would have CACHES or accountable communities for health, things like that are also common or collective impact organizations as well. So if you go to the next slide, this is just our standard definition of what a CIE is. I would just focus on the right-hand side and we kind of have the tenets and the core components and the how we kind of do it, which I'll walk through today. But really the goal of the overarching intention of this is really to address equity and anti-racism. That's really at its core. And how we do that is really through person-centered care, community stewardship, and multi-level impact. When I say multi-level impact, I mean micro, meso, macro. So we think about the individual that we're serving, the organizations. The meso is kind of the organizations working with one another. And then from a macro standpoint, how do we collect all this information and really support kind of community care planning or collective work to address disparities that we're seeing in our communities. And then we have some core components of the approaches we take. So that's again through that shared governance or network partners, shared language, closed loop referrals, technology. I'll talk about a little bit about all these things today, but that's really a way that kind of sums up the infrastructure in which we operate as a CIE. So if you go to the next slide, and I'm going to talk really fast so you guys can also ask questions at the end because there are 20 minutes is not a lot to talk about this. So I want to make sure everyone kind of gets the core components of what it is. So we have a shared network. We're at like, I think 124 partners that have information shared within or that are participating as members within our local network. We have shared participation agreements, business associate agreements, a shared consent or authorization that organizations use. So people opt into the CIE. And then we have this shared governance infrastructure that really operates like a learning network, and we support in real time what the needs are of the community in relation to this technical and governance infrastructure that we've built. So what's cool about it, because the focus is person-centered care, it doesn't matter which program or which population you're really focusing on. The tenets of the CIE really support any type of use case you're really trying to apply. Although we really started, I think most of us have, most organizations have heard how we started. It was really downtown San Diego, people experiencing homelessness, being transported by EMS to the ED, to jail, to the shelter, and there was no coordination between those individuals. This started 10 years ago with some thought leaders that were like, hey, what if we started asking these people if they were okay to have their information shared? And we started sharing and coordinating better, so they weren't just released to the street. They were actually coordinated between these agencies. And that's really how it started, really around information sharing. And so that's how it's evolved, again, over time to be this more comprehensive infrastructure for our community. We have some infrastructure around like shared language that we use to be able to look at people on a continuum. So we try to align different language from different sectors to be able to communicate, thinking about people not just in homelessness, but then you have to get into some sort of housing or, you know, thinking about, and then the continuum from homelessness to housing is a big one. So how do we start actually measuring that change over time? And what are the supports or resources or elements that are needed to ensure that that person gets to a more stable or thriving state versus a crisis state when they're experiencing homelessness? Bidirectional closed loop referrals, of course, leveraging our 2-in-1 database to be able to do that, and then having closed loop referrals. We have a technology infrastructure and data integration. So we have a platform that we leverage to be able to ingest information from multiple sources. We'll talk a little bit more about that later, but That's a huge component of it. It's really interoperability between different platforms. And then with the goal of having a longitudinal shared client record to be able to really support holistic, informed, trauma-informed needs that an individual is experiencing. How do you support that? So if you go to the next slide, these were the 124 organizations that I was mentioning. They really range on the healthcare side from health plans to hospitals to federally qualified health centers to various providers around that lens to social service providers like homeless service providers, multi-sector service providers, older adults, really range, and then government organizations, cities, our county, and then for-profit organizations specifically around CalAIM. We've seen an increase in that with the new contracted CalAIM providers locally to support a lot of the ECM and community support services as well. So if you go to the next slide, this is just a little bit about our opt-in model. I kind of mentioned this. So we have a shared authorization we currently use. All of this is public. We published our PA and our BAA and our authorization, so anyone can leverage it as a draft. We have about 300,000, probably 320,000 now individuals consented into the CIE. So the number increases every month. Really, our consent is it's a client-centric or a person-centered record, which historically maybe other organizations are used to a referral-centric method, or healthcare traditionally is used to a referral-centric method. So the way you access CIE is at a point of care. So as you're accessing the homeless information system or HMIS, we have a joint consent with that process. So you can also consent into CIE. Maybe when I'm registering for my intake at like the FQHC or something like that, I can consent into CIE. When I'm getting my food bank services, I can consent into CIE. So we really make it at point of care optional to have their information shared in. As we know, a lot of HIEs have an opt-in model. We really promote an opt-in model because of the sensitivity of the information that we're providing around like social services. So that's kind of our infrastructure that we have, but that's a little bit about how our authorization works. If you go to the next slide, this is just a little snapshot of what it looks like. And I know this is probably really hard to see on your screen. So I'll take it with a grain of salt to be able to understand, like, information kind of lives on the left-hand side. So we have a lot of demographic information or client information. You can hover over what you probably can see as little blue dots. You hover over those blue dots and you can see the agency that updated it, what value they changed, and what changed previously. So the date, the agency, and what value changed. And so we have, because we do so much interoperability and information integration into our system, information populates. So new phone numbers might populate or addresses might populate. Similar to a health information exchange that you can actually collect the information within that system. So it's around social information on the right-hand side. So we have domains, we call them. So we have 14 different social determinants of health information by housing, food insecurity, things like that you're able to really track people over time. And if you want to learn more, you can kind of click in and see more information in there. We have care teams, so organizations that are also working with people with that person, and you can sign up for alerts and get notifications as people move are transported via EMS or are arrested, or their food insecurity significantly changes, or their housing situation changes, where you can get notifications to proactively reach out. And then of course we have program enrollment referral information that lives within that profile as well. So we don't sell our technology, or we just, these are just models of information of how we kind of collect and share and what becomes important to our community based on the information or the projects that we have. If you go to the next slide, this is really just a focus on the value of data integration. So again, we really focus on ingesting information from multiple sources. I think dual data entry is probably one of the biggest challenges within any organization that operates. So one of our focuses, and again, the initial mission of our system was around data sharing. And so how do we aggregate that information into that longitudinal client record? So we use APIs. We run off of a Salesforce platform, but we use Informatica to be able to match data, upload data, ingest data from different sources. So we'll take data any way that organizations are able to share it. And so we have various levels of integration. Some are bidirectional, some are unidirectional, some are uploading it via an Excel, some are doing it a lot of different ways. And that way we're able to populate the relevant information that can be used by different organizations to really support that individual. So again, if you're getting information about where someone last went to the food bank or connected to was just seeking services at a homeless service provider. So we ingest data from our HMIS system. You can see they were already in the coordinated entry system, are already working with a local organization called Alpha Project. Instead of trying to, as a hospital discharge planner, I'm not reassessing for all these things or trying to refer them somewhere else. I'm able to see, oh, they already work with Alpha Project. They're already working with Joanne. I'm going to call Joanne instead of really tracking, following up on all the information again. So integration for us has been key, and interoperability to be able to ingest that information into the platform as well. So if you go to the next slide, relationship with HIE, we wanted to kind of highlight that. I know that was brought up as a topic. So relationship with HIE, we've had a long relationship with HIE, San Diego Health Connect. We've had a unidirectional integration where we actually push information into HIE. So we have a tab within the HIE that actually populates like program enrollment information. And similar to like a single sign-on, we're able to link to the CIE profile to be able to see more information about social needs. In our long partnership, we've really, there's a lot of overlap. And I think you guys mentioned in your initial mission, like where are we moving around? One of the big goals is addressing social needs. So recognizing we really have a robust infrastructure in San Diego around data and collaboration. 201 San Diego will be a parent subsidiary for the HIE. So we'll be really operating as separate organizations, but really identifying ways for us to align and partner on a lot of the strategic elements that I think are coming down the pipeline, specifically with policy, as you guys are reflecting on as part of this group, that we're going to be able to leverage to be able to really support data sharing, access, care coordination, and really support a lot of the outcomes I think that healthcare and social services are really moving towards. And so that's, this is all real new information, and we're kind of learning as we're going. This is a growing partnership as we kind of figure out what makes sense, but that's kind of the relationship we currently are going to remain separate legal entities, but really try to figure out where do we partner and strategically start moving together through our operations of alignment. And if you go to the next slide.
Karis, can I just ask about the governance again? You're making a distinction between 211, community exchange, and HIE. Is 211 the parent or is it the CIE?
211 will be the parent organization. So components of our board, our 211 board, we currently all have the same board, 211 and CIE. So we will have people from our board that will be on the leadership for the HIE.
Great, thank you.
Mm-hmm. So this goes a little bit back into data sharing. That was kind of the HIE segue into how we already share data with HIE is one example of an organization, and we share again with probably 26 different organizations we have at different levels of integration with, and in some cases those are, with HMIS that might be 30 to 50 sub-organizations that are populating data into HMIS and then populate into our system too. So we also do the closed loop referral, so really leveraging the 201 database to populate this. I think everyone's pretty familiar with the way that a closed loop referral works, but that's also a component of our system that people can leverage to be able to close the loop on services that they're seeking.
Hey, Karis, quick question. Are the area agencies on aging involved in this?
So our area of aging is part of our AIS, or our Aging and Independent Services, part of the county. So we work closely with our county. We actually have an integration. The county has the robust data sharing infrastructure of San Diego. We actually have a county shared system. So there's like a bunch of different departments that share a county system. They call it Connect Well. So we actually connect into their Connect Well system. We've also married our consents. So from the county, you actually do closed loop referrals through this platform so it's interoperable around the closed loop resource directory and then the pushing of those referrals in the system too. So that's the way that we've leveraged it. But I think we're continuing conversations on how to expand that work too. So
Okay,
everything is
terrific. I'd love to have an offline on that. Thank you.
Totally. And happy to connect you with our local county that's working on that too.
Terrific. Thank you.
If you go to the next slide, this is just kind of a high level overview of our CIE demographics. But this is really kind of speaking to the macro elements of how we're breaking out data and can start looking at it. We've actually used Tableau to help us upload these 300,000 individuals, and you can actually like filter and sort by population to be able to help, looking at specific health plans and then seeing how demographics change and how social determinant of health information changes. So how do we provide more access to the community to make real-time responses to what's happening locally? And we saw that a bunch, as everyone did with COVID, because we could see our health our needs change in real time, month by week, by month, we could see food insecurity was huge, and then it kind of moved to rental assistance and utility and all the different things. So that kind of data, which sometimes takes a long time to analyze because you're not getting it in from individuals, you're getting it aggregately from different sources. CIE allows you to respond in real time to kind of be more proactive with interventions based on the information that we're collecting in real time by partners in multiple sectors. If you go to the next slide, this is just a really high level of our CIE stewardship infrastructure. But again, as I mentioned before, it's a shared governance infrastructure, but it also really supports a learning network. So it's really a bottom-up infrastructure. We're hearing information from community members and community-based organizations or healthcare partners in real time that are doing the direct work with people, and then kind of pushing it up to our advisory board to help us make strategic decisions as a community to support that. So for example, if I'm a provider and I'm like, I'm having a hard time enrolling this person into a CalAIM service because I don't have the county benefit data that would help me to define the eligibility, that's an information we would collect directly from the people serving those individuals and populate that up and work with our relationships with the county or other organizations to be able to address those issues. So that's really the way in which our framework operates. And then we're able to really be responsive and supportive to our community and being able to address the challenges that we're seeing in San Diego. And if you go to the next slide, I can't remember how many more slides I have, but I know I'm running out of time. So primary use cases here. So it's really our primary use case, guys, is searching patients to see historical information on the use of social or healthcare services. So most of the time you're looking up, I want to see like the phone number change, or I want to see who this person is working for before, or this person just showed up to my office and I have no idea how to help them and support them. So a lot of people are just looking up information to see I want to look up Karis just to see if there is something I can support her with in this. She's my new patient or my new client, and I really want to ensure I'm creating a care plan that's supportive of where she's already tried services, or she's already used something, or she's already needed or addressed something. That's really where I want to add myself to the care team, because long-term, I'd like to be supportive of Karis's needs in the future. So that's kind of the primary use case of our system. We do have organizations using it for closed loop referrals. We have shared screening and tools that we use in the CIE that help address certain financial stability, or we have SDOH screeners or other intake tools that organizations use to collectively address those, and then alerts, those proactive alerts, to be able to kind of get notifications as things change. So we see a lot of our homeless service providers are using those alerts to be able to support around care coordination and servicing.
Karis, when you say alerts, does that include ADT?
Right now, it will include ADT. Right now, it's mostly EMS, so EMS transport. So when someone is transported in, and then jail alerts. So when someone's arrested or reentry, we're working on reentry data right now, or when a significant event happens. So we define those in a bunch of different ways. The communities define those, but there's about like their homeless situation significantly changed. So if we get an update that they just been registered for HMIS or something like that, we can get that notification out to providers so that they can follow up on those needs right away.
I'm going to go to another question here, if that's all right.
Sure.
Doug? Oh,
Yes, we get eligibility list for the health plans for the patients that are Medi or the Medicaid managed care, and we struggle with being able to contact them with current phone numbers and addresses and stuff like that, and it gravely impacts our quality scores and everything like that. Is there any work that you guys are doing to help the network providers get a hold of these patients and get them to come in for a basic HRA and stuff?
Yeah, that's a great question, Doug. And I mean, the way that we're seeing that right now, and we're doing a lot of pilot work groups around CalAIM specifically for like ESO, similarly with ECM or in enhanced case management through CalAIM or community support. So you're getting lists from health plans to be able to outreach to individuals to enroll them in these services. Or health plans are providing these lists. And so we're really working with the providers to be able to leverage CIE for updated contact information. So that's probably one of the main uses, like you're saying, is to be able to get an updated phone number. So like maybe they called 211 and we just updated their phone number, or address, or contact. So that's one of the primary uses specifically to be able to do that. We're also working with the health plans to get lists of who's eligible and who's enrolled in those programs so that you'd be able to get notified. Let's say this person is eligible for the program, like you're saying, a Medi program. And then we can, other agencies, let's say they just go to the food bank or something, and then their agency sees that they're eligible. You're able to say, oh, great, I can connect you. Like it looks like you're eligible for this awesome program. Doug can work with you. Here's his contact information. Can you reach out? So it's the opportunity to be able to kind of leverage that eligibility information, not requiring you to just find them, but other service providers to encourage them to get connected to that. That's also been really significant with enrollment in ECM or CS. So if they are like with a discharge plan at a hospital, they're already enrolled in this program, instead of the poor social worker trying to find where am I going to place them, I can reach out to that person at that organization to plug them back in. So we're kind of, we did that with whole person wellness or whole person care early on with the services. But I think we find that like the lists are challenging in general, but this is a leverage point to be able to do that. It's usually like hot leads. I call them to be able, you've already identified them in the community and you're like, hey, this person needs your support, that we're finding more of a use case, but what you're talking about is what we're leveraging it for currently for CalAIM.
That's awesome. Yeah, because we need more of that in more counties doing the same thing. It's such a struggle. And like you cased the discharge planning and getting them back into, I mean, we know they're inevitably going to be readmitted if they don't get into some type of chronic case management program for their care, especially when it comes to behavioral health, and hopefully CalAIM is going to help us with a lot of that stuff.
Yeah, this is phenomenal. It's why we're excited to be able to share this with everybody. A lot of our programming, we look to other states and how successful they are, but to be able to have this type of merging of HIE with social services is just such a great example. So Karis, it's fabulous. I know I cut you short here on your slides. Do you have any other wrap-up slides you want to make?
Yeah,
sure
maybe if you just go, I can just leave you with the last slide. Hopefully skip this slide. Skip this slide. You guys will have these after anyways. I think the last thing Robbie had asked me to talk about was just like, where are we going? And I think that you're already alluding to this, like alignment with a lot of the statewide policies and shifts with Medicaid, building local governance and technical infrastructure to support the capacity building. Just being, I mean, these are just takeaways. If you're building this in other communities, we'd love to encourage. And we're starting a California Learning Forum. We had a California CIE event in August, and we'll be starting a California Learning Forum, so we can share that with this group, so that if organizations are interested in participating, work is focused on agencies that are trying to build community information exchange models. But these are just kind of takeaways around, like, we're thinking about interoperability. How do we align with Z codes and a lot of the HCD gravity project kind of initiatives and the DHCS priorities, fire standards and aligning with EPIC and those things. And then community voice is always a huge element to making this work. And so how do we actually include community voice and community experience into this? Has always been a core component of what we do, but we can always do better. So just wanted to share those as things to be thinking about too in your own organizations, and like really the local governance is probably the hugest key to making this work. Is we are local to, it's not, it's replicable, just like HIEs are replicable, but they look different in every community and county. So just making sure that that's well taken and influenced to be able to really support those needs too. So anything else that I can cover?
No, this is fabulous. And thank you so much. And it would be great if you could share your contact information, maybe put that in the chat, because I'm sure there's going to be a lot of follow-up offline. And, you know, if we could have you come back next quarter even to be able to give us some updates on how you're doing. We really appreciate you being here today. Awesome. Thank you. So I'm going to now move us along with Kate. And again, Kate Kiefer presented a few months ago with the work that she did with the California Healthcare Foundation on how the state can think about funding HIE and HIE infrastructure and the network effect. And we followed up with her and said, this is such great thinking. How can we continue this to be able to be, you know, get down to peeling that onion? What's the next level? And Kate's here today. We'll walk through some of her initial thinking, and based on your input, we'll work with her to get a fact sheet out or a paper too. So as a next step, Kate.
Great, thank you so much, Timmy, and thanks everyone for your grace and flexibility with some of my availability lately. Let's go ahead and go to the next slide. I'm just going to go through just some conceptual context information and some of the concepts on how to kind of think about executing and going to the next step. This work is built off of a paper that Lauren Glock and I from Aurora Health Group and I did with the California Healthcare Foundation around closing the data exchange gaps in California and identifying different funding opportunities. So it's built from that and has a little more conceptual and potential tactics that can be taken. Next slide, please. So the premise of this is, you know, how do we advance the data collection and sharing and use among the delivery systems and across sectors? And there's opportunities to inform the public and private sectors and how to coordinate this data and technology and infrastructure and these funding strategies. There's a lot of shared priorities amongst the stakeholders in California. And I think that there could be a blueprint and a strategies for moving those forward and really mapping all those opportunities together. Next slide, please. All right, so just to give the context, this was from the House Ways and Means of the different programs that serve and have benefits and services for low-income individuals. So you can see in the middle, there's some food, energy, health, but there's housing, all those different things similar to what Karis was talking about. This doesn't even include some of the public health programs that are also dealing with some of the activities in supporting maternal health, chronic disease, and prevention, those types of things. But it shows that at the federal level and the funding, it's siloed and it's at a lot of different places. So how do you map that together? Next slide, please. So just to give some context, in the original CHCF paper, and they even just had, Academy Health just had a webinar about this as well. But just to give some definitions about what I mean when I say braiding funding, blending funding, or stacking funding. So with braiding funding, it basically means coordinating two or more funding streams, but maintaining the funding stream's connection back to its original source and their objectives. So let's say you wanted to do something around chronic disease, you might have some CDC funding for 1 million hearts, but then you might also have a Medicaid funding around reducing diabetes for specific Medicaid populations. So they have specific program requirements, but there's a way that you can braid that funding together for some of those shared data and technology investments. Blending funding is more about pooling the resources into a funding stream to have more flexibility. So there are some states that do this with state health IT funds, but this is a way where you can blend the money together. It could be private money, philanthropy, state money, federal money, but there's ways to kind of pull it together to then kind of go after some shared priorities and shared investments. And then stacking funding refers to kind of layering different funding sources with shared services or making investments into reusable services or reusable infrastructure so that you don't have to invest in it every single time. Next slide, please. So the first concept to talk with here is there's a lot of things around social determinants of health programs. California has done some amazing work in investing in these different programs. There's a lot of work that's also happening at the national level. So the White House just had a conference on hunger, nutrition, and health, and identified different funding and public and private sector cooperation around that. There's a lot of activity and priorities around maternal and child health, and there's a lot of activities and funding around health equity. So in look at these, identify some of the different health funding efforts and showing that they're in different agencies, but if you look, they're different populations. Some might be a behavioral population, some might be mothers, some might be children, some might be aging populations or low income. But just because they might be different populations doesn't mean they don't have similar technology needs and investments. So what is a way for you to stack them up? And Kara's kind of mentioned it about the county level. So as the money might go down to these different divisions of the counties, how can they identify different ways to share or reuse systems with the different functionality and technology needs, and just identify the funding to help support funding those services, but they don't have to have an individual investment into a platform or to service for each individual program. So how can you start to stack and reuse those together? And I also want to point out that it's not just Medicaid. There are commercial and Medicare programs that also need similar assets. So what is a way to really coordinate those and see where there can be some opportunities for alignment around those activities? Next slide, please. Also, the second concept is around how do you modernize and integrate public health services and for data and technology. California has done some amazing work and investments around workforce and increasing the public health workforce, also improving the foundational structure of public health services, and also some different activities around modernized public health data services. But you can't have you need the services, you need the workforce, but you also need the data and technology for the tools so they can actually do those different services. So there's opportunities to bring public health data systems connecting to the health delivery system and social networks, and see if there's opportunities to reuse investments there. There's also aligning it to the data exchange framework. There's also an opportunity around maximizing the use of the Medicaid 90-10 match for planning. So you can do MES, Medicaid Enterprise Systems, and they allow 90-10 funding for planning, design, development, implementation. And there are other states that have done public health technology modernization planning, and they've received Medicaid 90-10 to do so. So if public health got $1 million, they can get another $9 million from CMS and have a $10 million for planning. So expound that by how much money California has already dedicated to public health modernization. And there's an opportunity to really take advantage and have some really good planning money and integration with those things that if it's coordinated. And the public health data is beyond just infectious disease surveillance. It's preparedness, response, recovery. It's prevention for vulnerable populations and chronic conditions. And there's just a lot of alignment there. I think that that could be really braided together for their funding. Next slide, please. This third one is conceptual, but I think that it's something to start planting the seed in. So Governor Newsom signed a sweeping climate measures with the California Climate Commitment, and I identified many parts around climate change and different activities and updates in California, but also pointed out some very important things around how climate change is increasing the healthcare sector and accelerating the action and it's impacting health equity and impacting health. The White House also had an executive order around some of the climate change and some of the impacts to health equity. I also have a resource here around there's an Office of Climate Change and Health Equity. They have a webinar series where they bring in different agencies that talk about the impacts to health and different ways to think about it. And they even have a funding resource compendium of which agencies have different funding opportunities for different parts of the health sector, whether it's provider settings like hospitals or long-term care, or even FEMA and BRIC funding, the Building Resilience in Community. But there's lots of different funding, and it has it's significantly increased in some of those areas over the last couple of years. And so the Office of Climate Change and Health Equity could just be really important. But for a California perspective, just think about expanding social needs and risk assessments to include also environmental risk and environmental needs. There's also an opportunity to strengthen the capacity of the health data infrastructure to support the climate change and impacts to health. You can build on the existing surveillance and data collection and integrate the data for a broader surveillance and analytics of how it's impacting the health of Californians. And then there's opportunities to evaluate different funding from kind of not typical federal agencies that also might be able to support some of the health delivery systems activities. Next slide, please. And these are just some tactics for California to consider. So one, there's a lot of funding opportunities coming down. California is doing amazing things about investing at the state level, but there's opportunity to coordinate some of those funding strategies and investments across the agencies. Many states have cross-agency task force or coalitions to make sure that they identify the different technology needs, align the strategies, identify parallel efforts, and then he also put in funding requests across the agencies for kind of a blended approach. And there's an opportunity for the next one around maximizing the federal match and for planning, implementation, and maintenance to maybe do a cross-agency planning investment that might be matched at 90% and think about how much impact that can do if it's done coordinated. There's an amazing opportunity and a need to continue to align at the program and investments at the county level. The data and infrastructure is so imperative at the county level. So how do you keep that and share across different counties or have shared systems or shared approaches, or rather than trying to each county build their own thing, was the opportunity to have some economies of scale there. And the last is assess and integrate data and interoperability and technology needs into all health transformation activities. There's opportunities to do a data and technology assessment for new services and new programs, but also seeing if things are already there and what can we already be built from. And see that there's just a way of, there's new policy coming down or funding coming down, assessing the technology needs ahead of that. So there's always a portion of the funding that might be available to help support the initiative that's being invested in. So all in all, there's still a lot of extra things that there's in the notes, I think in the slides that are sent out, there's a lot of other examples. There's even things that have come up in other agencies like HRSA around maternal and child health and state innovating state systems. There's a lot of activities coming down the pike. So I'm happy to always come back and keep you guys aware of these things. But I want to emphasize that there's federal funding, state funding, private sector can also contribute to these things, as well as philanthropy. So there's just a really great way to braid, blend, and stack all that the funding that might be available. Timmy, hopefully that was fairly clear. I know I did it fast. I don't know if there's time for any questions, but I'm happy to answer any.
I'm on mute. I definitely want to open it up for questions. I think this is exactly what we were looking for, and we can work with you on, just thinking about, I'm always thinking about this, like what funds is the state leaving on the table by not, taking advantage of some of these additional pipelines. And I don't know if that's something that you can work on with us, or if you have some initial thoughts.
Yeah, I think that there's, I think the investments in just being more familiar with California's last couple of budget years, I think the most important thing is the state level investment is impressive. So how can you actually maximize federal participation in that? There are, and like the vaccination programs, 50% of the states don't receive any state funding for their public health vaccination program. They're reliant upon CDC. So for the state to have funds to do that is significant. So how can you leverage them in such a way where you can maximize and use those for a state share? Like with the BRIC funding, it's a 25% state match and then 75% federal. For Medicaid, it's It can be 10% state match, 9%. And I'd also say really be creative about how you need that match. That match is not required to be general funds. There are other ways to contribute to that match.
Fantastic. Open it up to any other additional questions for Kate?
Hi, this is Daniel. Can you hear me?
Yeah, hi, Daniel.
Hey, hi. Hey, Kate. Hey, I had a question about cost allocation when you're starting to blend federal funds. A87 got sunsetted a couple of years ago. And I don't know if you guys considered that in the paper in terms of how to address the federal requirements for cost allocation at the state level and whether or not there's any particular strategy or approach or models that you're using.
There's, unfortunately, there's not one model and there's not great guidance around it. So there is always going to be to leverage the CMS Medicaid 90/10 match that Medicaid will only pay for their fair share. That said, there could be some opportunities around public health. The state of Washington got their public health planning approved APD for 90/10. The interesting thing is some other states have gotten up to about 82% cost allocation based on workforce, based on different data calculations. There's lots of ways. I think they're open to different approaches. I do think it'd be worthwhile to do almost an actual calculated model of, okay, let's do a scenario of all these things in the last 2 years and see what if we'd taken 25% of those funds and put them into a planning and seeing how much money would have been there. That would have been very interesting. As for the A87 waiver, there is a momentum. NESCO is trying to, the New England State Consortium for Systems Organization is trying to pull together groups to advocate for A87 waiver. And I think an A87 waiver for the cost allocation for public health could go a long way.
Yeah.
That's fantastic. And I also love the idea of climate change, especially here with how important it is in California for our policymakers and where and how that crosses over into health and public health. I think there's a lot there that we could also pull through. Well, thank you, Kate, this is a continued conversation. If any of you have additional questions, Kate, if you can put your—
One more.
Oh, yep, go ahead, Daniel.
Sorry, one more question. Sorry about that. One of the challenges has always been reporting, and because I'm not sure how you consider the individual reporting requirements when you blend and braid funding, and if there's discussion about that in your paper, because there's a lot of duplicate activity.
Yeah, 100%. I think a lot of states take the path of least resistance when it comes to funding. So there might be 3 funding options, but all of a sudden this one's a lot easier to get and it's less reporting requirements. So, ideally, what if there's also an opportunity to, if you do some cross-agency work, cross-agency coordination, what if you account for that in the administrative funds at a 50/50 or whatever rate for some coordinated program reporting, so you don't have to have that burden of and have some of that coordination across the funding that's coming down, where you might be able to share some human resources in order to do so. I think that there are some creative ways to look at that because it does get very cumbersome, but what if there's a way to factor that into some of your matching?
Just a suggestion or a thought. Many years ago, I learned about the 477 waiver, which was provided to the Native American communities who were braiding and blending their funding, which allowed them to consolidate their reporting back to the federal government. And I always have thought that that was a model that could be hugely relevant for non-Native Americans. I don't think it ever went anywhere, but it was legislatively provided to them. It would be interesting to look at that.
Yeah, absolutely. And there was a couple of things also. Indian Health Services has a lot of funding coming down. I'm not sure how California's Health Data Network has aligned or integrated with the Indian Health Services or even VA, but those are other considerations as well. Those are, and a lot of times there's some creative ways I think that Indian Health Services can maximize and not have the cost allocation as rigorous or as stringent for Medicaid match. So that might be also an opportunity. A
huge opportunity for us, I think, given our landscape. All right, well, thank you, Kate. I'm going to move us to our next agenda item. And again, I see you put your email in the chat. Thank you so much. And I offer the networking to happen outside of this meeting as well, and we will follow up. So I want to hand it over. I think, Lori, you're on. If you,
Great, thank you. Wow,
Yeah,
that was
thank you.
so interesting. Kate, thank you for that advice about funding. After listening to Kara's talk about the whole local initiative in San Diego, I sort of wanted to say, okay, I rest my case for qualifying HIO criteria. We have been working off of the outline that was developed at the last CDII meeting, which really had 4 broad categories for helping to define what a qualifying HIO was. They're looking at, of course, organizational structure, governance, and just sort of the status of an entity. And then secondarily, they're looking at functional capabilities, to be able to support the data exchange scenarios that we've been developing with CDII to support the legislation over the last 6 or 8 months. Those, of course, include data privacy and security technologies as well as practices. And I think Kara's gave us just a really wonderful outline about why we're really recommending that the organizational structure be a community-based nonprofit made up of the stakeholders who are trying to support not only patient care, but social services, the sort of whole person care that we're looking for. So this recommendation that we're making to work to define the qualifications are really around how the community is supporting a longitudinal record for the patient, providing connectivity among not only healthcare providers, but social services. And as we saw this wonderful example in San Diego, also with a whole variety of support care areas and across those scenarios that do include jail settings and so forth. So really, I think some of the basics are in alignment with some of the TAPCA requirements, some of the things that we're seeing from federal standards around having adequate insurance coverage, certainly cyber security insurance, having financial stability, making sure that the organization is sound and that it is really working from a perspective, as we've seen many of the HIOs, with a multitude of stakeholders at the table to help define what that local community needs, but also then connecting from a technical perspective with the broader California and even federal technology providers. So one of the key things that we are really focused on is healthcare is local. California regulations are slightly different. We want an open and transparent organization to be deemed as the qualifying HIO, so that so we can focus on delivering the California data that's needed for this whole person care. And then secondarily, the issue with regard to technical capability, and thank you, Wes, your question about service accountability. It's really about some of the requirements that are already in place in the policies and procedures around C10, primarily around when you're getting a data request that you need to respond to it. So as we work HIO to HIO in the state, the technology is bidirectional. As Karis was mentioning, if a query comes across, you need to respond in a timely manner. We're helping to define what real-time data is. And then finally, because I know we're running out of time, just making sure that we are following a roadmap for the reality of data exchange in California. So unlike Texas, which I know relies heavily on direct messaging, and also other states that are looking towards fire interfaces, in California, we haven't taken advantage or utilized direct. We've been using some other means of supplying ADT feeds, using HL7 feeds, and utilizing some of the national networks to connect one local market to another. So we want to continue to utilize that to leverage some of the fire capabilities, but to understand that many of the EHRs that are being utilized in California just can't support that technology at this time. So it's a lot for just a couple minutes, but I did want to, any feedback that any of you have, please share that with us. We're glad to bring those ideas forward and continue our dialogue with CDII.
On mute. Lori, what is your timeline for this, for getting you feedback?
We need the feedback as soon as possible. We're developing all of the recommendations in the next week or two. CDII is on an amazingly fast track to try to establish the qualifications rapidly so that we can meet the legislative timeline. So if you can get back to us by the 21st, that would be amazing. And let me just put my contact information in the chat.
Fantastic. Yes, please do that. And I think there's a lot going on right now. Of course, I say that a lot, but with the work that's being done at the state with the data exchange framework and the policies and procedure implementation group, as well as the implementation advisory group. And this is one of them. I think it's just such a timely piece that's gonna, needs to be solidified over the next, month or so, I guess, that this will be part of their agenda, right?
Absolutely. And they're working as rapidly as possible. Actually, as fast as I've ever seen a government agency work.
Yeah, exactly. And kudos to the team. I know we're at the top of the hour. I just want to see if we can get through a few of these highlights for you. Thank you, Lori, for sharing this with us. And for all of you, I think there is a call to action here for the qualified HIOs that, reach out to Lori and be able to have comments and discussion with her as well as they're gathering. Just very quickly to put on your radar, there are upcoming meetings for the data exchange framework. And I was on the listening session this week. It was fabulous. You'll see some of the screenshots we have in the next couple of slides. I highly recommend for you to share these listening sessions with your colleagues. I think and also be able to kind of get the word out with community organizations, because it's really good to be able to get this insight back to the state as quickly as possible. If you go next slide quickly, please. For you all, you should have some meetings on your calendar, and I will highlight November 17th will be our legislative or policy briefing that we do every year. So more there. And then finally, if you just go to the next few slides. I want to do a shout out. If you can please let us know if you're going to be at the California Association of Health Plans conference. We are holding a networking session and co-hosting it with Manifest Medic. So let us know if you're going to be there, and we would be happy to make sure that you're on the invite. Again, a great way for us to be able to network together. We were all able to get together at Civitas in last month in Austin, where we partnered with Lori. So anyway, I just think it's a great way. If you have some ideas where you want to co-host with us too, let's partner. And then the real quick, next slide. Thank you. And then here's a whole list. You have the slide in your emails, but other news that we're following, as well as other events that you probably will find very meaningful and useful. So take a look here, send us more so that we can put it in our roundup. Thank you everyone for being here today. Thank you for our presenters, and have a great day. Have a great week. Take care.